If you have any questions, feel free to enter them into chat. Feel free to unmute yourself, whatever is more convenient for you. The clinical case conference we're going to go through today is a little bit different format than what we usually have for our clinical case conferences, in that we're not going to really go through root cause analysis or fishbone diagrams or anything of that nature. We're just going to talk about an interesting case, kind of a more classic M&M type format. And this is a case of a patient that I took care of a little over a month ago. So without further ado, we have a 54-year-old man who is presenting for complex spine surgery. And I'll go into the details of what that surgery is later, but you can see that he has a list of various comorbidities: hypertension, diabetes, hypothyroid, renal insufficiency, sleep apnea, chronic pain, obesity, bipolar, and GERD. And so this is a patient that, for all of these comorbidities, was pretty well controlled and was in a good baseline state prior to surgery. So this is a patient that we went into the OR. We had an unremarkable induction. We gave fentanyl, methadone, lidocaine, propofol, and rocuronium for induction. We had an easy mask, and we used a video laryngoscope to secure the airway. Didn't have a whole lot of problem with that. Got 2 large bore IVs and a radial arterial line for the case. We maintained the patient on IV infusion anesthetic because he was having neuromonitoring that was done concurrently. So it was propofol infusions, ketamine, dexmedetomidine, and lidocaine infusions on top of that. And then for the case, this is a patient that had a lot of EBL. We had 5 liters approximately of EBL during the case, made a good amount of urine during the case, which we'll talk about in a little bit. Did get some PRBCs, did get some FFP, also got some cell saver, quite a bit of albumin and quite a bit of crystalloid. So this was, not a very easy case to care for in terms of volume status. So really the interesting things, I'll kind of take you through some of the pieces of intraoperative records so that you can kind of see. I don't have labels on here, but you can see that at the top we have induction. Patient drops down their blood pressure. That next reading after induction is that systolic reading is 100. And you can see that it stays relatively stable through that early part, getting the patient set up for surgery and starting with incision. And then during the case, again, this is a first start case, so this is 7:30 start. Really for the first 5 hours or so, the case was going pretty unremarkably. We would have jumps of EBL of 200 or 300 at a time. But then we got into about the 1:30, 2 o'clock time frame, and that's what this is showing here. If you look at the far left, you can kind of see this trend of blood pressure that is concurrent with about a 500 cc loss of blood. We then transfuse the patient. You can see the uptick in that blood pressure as you get towards the middle of the screen. And then when you start to see a little bit more of that lability, we had almost a liter of EBL during that about 15-20 minute segment. And so that EBL that we got was as a result of a osteotomy that they were working on. And for those of you that have not done much spine up to this point, this particular osteotomy was called a pedicle subtraction osteotomy. This particular osteotomy is a PSO. You'll hear that. Don't confuse it with an SPO, which is a Smith-Peterson osteotomy. Whenever you have a pedicle subtraction osteotomy, that is a significant wedge resection of vertebral body and pedicle out of that vertebral column. And the goal of that osteotomy is to allow for a increased curvature of the spine so that you can get some lordosis and people can stand more upright. Every time you do a PSO, a liter of EBL is sort of a minimum that you can expect to have. And so in this middle section here that you see, that's really where they're doing the PSO, lots of blood loss, lots of product at that time. And then you can kind of see it start to even out. So really the span of about 2 hours that's on here is where we had about 2 liters of those 5 liters EBL in a short time period. And then the end of the case, you can see that, we're still kind of a little bit softer pressures. 100 for systolics is kind of where we were running towards the end of the case. And then you see this transition of your heart rate. You can see the blue dots on the left part of the screen. You can see it transition to black dots. That was the transition of the patient being flipped from a prone position back onto the gurney into a supine position. And so what had happened at that point, in most cases, you have your infusions that you shut off. You wait for the patient to wake up. And in this case, the patient didn't really wake up, and that's really the purpose of this discussion today, is to talk about delayed emergence. And so what happened with this particular case, I actually handed off the case at about 3 o'clock, a little bit before 3, to one of my colleagues. And at that time, I find out, the exciting parts of the case were done. They were closing. We didn't have really any need for additional products. Blood gases, which I'll show you in a moment, were reassuring that we were, from a hemodynamic standpoint and a volume standpoint, we were probably euvolemic. And really the thought was, okay, you're gonna just have to wake up this patient, extubate, and go to PACU. Well, what you see is that, they stayed in the OR for about 45 minutes in this supine position, almost an hour, and the patient didn't wake up. The patient was breathing spontaneously the entire time, but was not really having any meaningful responses to stimulation or to command. So the decision was made at that point by the person that took over for me to take the patient to the PACU, still intubated. And we do this a fair amount. If you've done spines, don't be surprised if you get to the end of the case and if the patient's breathing, but not yet woken up, that you can take them to the PACU and have them there. Usually they can extubate within the first 15, 30 minutes of getting to PACU. So what you see on this screen is the series of ABGs intraoperatively. So you can see that about every hour to 2 hours is the frequency that we were getting blood gases. And I'll point out that if you look at the base excess, especially the one at the 1 o'clock, the 13:33 time, we were at minus 2.1 for our base excess. That went to minus 3.4. That was really that section where we had about 2 liters of EBL from PRBCs. And so you can see we got a little bit behind, but then it plateaued by the end of the case, which was right around 3:30. So this is what the note was for the APP dropping off the patient in PACU. You can see that blood pressure is stable. There's no hemodynamic or vasoactive substances that are needed. Heart rate was stable. Patient was breathing at a rate of 14. Temperature was normothermic, and fatting appropriately at that point was on a T-piece of oxygen. So in the PACU, the first ABG that you see from PACU is at 1720, and you can see that the CO2 is stable. You have a little bit more of a jump in your base deficit, but again, these are not terrible numbers from the standpoint of the amount of EBL that the patient had lost. But what was interesting is that the patient stayed in the PACU for an hour and still had no meaningful change in mental status, no response to commands, no response to stimulation. And so at that point, the person that took over for me had called the neuro ICU and says, this patient I don't think is going to be ready to extubate. We want to just transport directly to the neuro ICU with the patient intubated. So that's what happened. Now, from as I mentioned, the postoperative course, an hour had passed with no return of consciousness, transferred to the ICU. Now, I just want to stop there for a moment and allow a little bit of discussion or conversation. Again, feel free to unmute yourself or to put something in chat. What are some thoughts about what could be going on in this case?
Like hypoglycemia, stroke, unreversed or ineffectively reversed. Well, he's breathing spontaneously, another neuromuscular blockade.
Yeah, those are all really good things. We'll go into sort of the differential in a little bit more depth here in a second. But yeah, so a lot of the things that you would want to check and want to know about, electrolytes, glucose, obviously ABGs we had been doing, but those things were checking out to be unremarkable. And so I think the interesting pieces start to happen once we got to the ICU, and I'll talk about that in a little bit. So some of the people that have worked with me and talked about delayed emergence have heard me use this acronym, DAMN, D-A-M-N, and I have a little a on there for a reason, and I'll talk about that in a moment. But this is a way for you to think through a patient that is having delayed emergence and trying to come up with your differential as well as a plan for management. So the first thing is drugs. Drugs is going to be far and away the most common reason that people are going to have delayed emergence. And the small a really signifies the unique aspect for us, which is the anesthetic drugs, right? So you not only think about what we have given from an anesthesia standpoint, but you also have to be thinking about drugs that the patient's taking concurrently, previous to the procedure, any polypharmacy of your own anesthetic that could be leading to drug interactions and other things. So that's a big component. We'll talk about that more. The M is for metabolic derangements. This also is something that is really important in trying to elucidate why the patient isn't waking up. And then the last is the neurologic. So as Jesse alluded to, stroke, other things are things that you consider as a reason why somebody isn't getting to be awake as you expect them to be. So we're going to get into my family feud that I like to do, and I'm just going to call on people for this. Let me change my view real quick. Hold on. All right, so this one is name a drug class that can contribute to delayed emergence. So these are drugs. Again, name a drug class that can contribute to delayed emergence. Very broad. Annie.
Benzos.
Say it one more time. I didn't quite hear you.
Sorry, benzodiazepines.
Benzos. Yes. Cesar.
Opioids.
Opioids. Yes. Cindy.
Sorry. Volatile anesthetics.
Oh, I just lumped a bunch of anesthetics there, volatile as well as IV anesthetics. Yes. Dan.
Can I say Presidex? I guess that's maybe an anesthetic as well.
That is, I have it separate, so alpha-2 agonist, yes. So clonidine and dexamethasone for sure. David Leopold.
Oh, dang it.
Antipsychotics, like how low?
So I'm going to put that in this category here. It's not antipsychotics per se, but anticholinergics. I'm going to put there. You're so excited, David Maurer. Why don't you go ahead?
He stole mine. I was going to say, like Benadryl.
Yeah, that definitely is one that is a common culprit. How about David Mack? How about Eric Yu?
Testing, can you hear me?
Yeah, I can hear you.
Pregabalin or gabapentin?
So I don't have those on here. The gabapentin is probably more likely to cause that level of sedation, but pregabalin also. I don't have those up here though. Gisela.
Can I take a second stab?
No,
Other GABA agonists like propofol, I don't know if that's in the anesthetic category.
It is in the anesthetic category, yes.
I don't know, maybe like muscle relaxants we didn't reverse enough.
Good. Yeah, so neuromuscular blockers, good. And then the other one's kind of like guess what I'm thinking, so I won't have anybody else guess. But you know, illicit drugs, alcohol being the one, right? So if you have acute intoxication, that's one that you want to be considering for something that could be leading to them not wanting to wake up. So you always want to be thinking about polypharmacy. As we said, for anesthetics, that can be volatile, that can be propofol. Ketamine is actually one that can be very problematic. So that's why in these long cases, if you're doing a ketamine infusion or if you're doing ketamine boluses, you really want to be considering what the total dose is over that period of time. I actually had the misfortune of working with an intern that was going into anesthesia when I was a resident. I was a CA1, and it was at the end of my CA1 year, and this guy's getting ready to start his CA1 year, and I said, hey, why don't you go ahead and get the medications together, drop some fentanyl, drop some midazolam, and he did that. And during the case, we're just doing this inguinal hernia repair, and I'm giving what I thought was 50 mics at a time, 1 cc at a time of fentanyl, and it turns out at the end of the case that he had actually drawn up 300 milligrams of ketamine. They were in these ampules that looked a lot like the fentanyl ampules. And so over the course of this case, this patient got 300 milligrams of ketamine. And he was gorked out of his mind in recovery, completely unresponsive, but breathing. But that's one of the things that you want to be thinking about is, how much are they getting and how much is too much. The narcotics, the opiates, and what we see for these spine cases, we often worry about opiates as the reason why they're not waking up. But in this particular case for this gentleman, he was breathing. And if the patient's breathing, then your opiate probably is not the reason why they're not waking up. Because if the opiate concentration was high enough, they likely wouldn't be breathing either. As with respect to your benzos, this is, in our experience, in most cases, not going to be something that you worry about. The doses that we give for midazolam and lorazepam postoperatively are usually not going to have this profound sedation. Same thing with the alpha-2 agonists. You do get some of that sedation, but usually they're responsive, right? I mean, they seem like they're completely out of it, but then you shake them and they open their eyes and can respond to you. The anticholinergic stuff, as David Leopold mentioned, you have some psychiatric medications that can be clouding the picture. We'll talk about that in just a little while too. But it's also medications that you're giving, right? So agents that you give either IV or otherwise that could be creating a situation where the patient is delirious postoperatively, and maybe it's a hypoactive delirium that is contributing. The neuromuscular blocker is a pretty fascinating one. I think it really used to be something that was more common before Sugamidex, and residual weakness or maybe unrecognized weakness were things that happened probably more regularly and were more of the reason that patients wouldn't be responsive. In this day and age, especially if you have Sugamidex, it's not as much of a concern. When we're doing these cases with IV anesthesia and they're doing motor evoked potentials, you obviously can't be paralyzing them. So you likely have had enough time to pass to where all of that neuromuscular blocker has worn off. So that's also less of a concern. One of the things that can happen though, and that I think we've talked about this before within one of the ITE knowledge gaps lectures, is that there's a fair number of people, it's not a high number, but enough to where you'll see somebody that has this in your career that has pseudocholinesterase deficiency. And let's presume that you give succinylcholine as a neuromuscular blocker to get the airway secure at the beginning of the case. If they have a deficiency that's homozygous in nature, they could be without any twitches for 4 hours. And so that's something to be considered as well. So, if in this situation, if the patient wasn't breathing, wasn't responsive, it would be prudent to go ahead and check for twitches make sure that weakness is not one of the reasons why the patient's not responding. All right, any questions about the different medications that can be causative of delayed emergence? Let me look at chat real fast since I had to move it off the screen. All right, so Cindy says, yes, at least you got a really good trip. That is exactly right. Jack Dong, would you ever put an EEG monitor on as part of your workup? We'll get to that in a moment because that's actually a very good point. All right, so moving on to the next one of your differential. This one is going to be name a metabolic disorder that can contribute to delayed emergence. So metabolic causes for delayed emergence. All right, so let's do Daniel Paz de Arujo.
Hypercarbia.
Hypercarbia is one of them. Let me get that highlighted real quick. Let's go to Grace.
Sorry, I was talking and not unmuted. Patient could be hypoglycemic.
Good, so I have that right here for glycemia. So hypoglycemic is the thing that we think about most of the time, but it also could be hyperglycemia too if you have extreme cases. Ian.
Hypoxia.
Good, so hypoxemia, definitely. How about Jack?
Did you say Jack or Jess? Oh, acid base, okay.
Well, how about, go ahead, Jess.
Well, I was gonna say something like hyperuremia.
Oh my gosh, you're thinking so advanced. Would the hyperuremia be related to something else, or you're talking about just as a standalone?
I mean, it could also be related to something like hyperkalemia, but so renal disease could be something.
The renal disease is actually something that I don't have on here, but that you're exactly right. That is something that renal disease could be playing a role because you're not able to clear some of these agents. Let me look at what Jack put in. So Jack said acid base. So yes, I have acidosis. Janine.
I'm sorry, I just joined because I just got out of the OR. I'm not sure what we're talking about right now.
So name a metabolic disturbance or disorder that contributes to delayed emergence.
Oh, you already said some of the. See. Like liver disease potentially. So I'm thinking. Like,
You got it.
Delayed metabolism.
You're exactly right. So thyroid, liver disease that has, issues with metabolism could be a component without a doubt. And that actually goes into part of your differential too. If you have succinylcholine that you've given and they have pseudocholinesterase deficiency, you can have acquired pseudocholinesterase deficiency that's not related to genetics at all. That's largely based on liver disease. Jake.
Hyponatremia.
Good. So sodium, super important. Usually hypo is what we worry most about. Let's see. Jesse, do you got one?
Getting kind of tough. Pronounced hypocalcemia.
That's not something that shows up very often. I haven't seen anything where calcium is something that people look at first, so it's not up here. Good try.
Did you say hypothyroidism?
Oh, so who just said that?
Oh, that was me, Janine.
All right. Yes. So thyroid disease, hypothyroid specifically, yes. Kevin Kim, can you clear it?
I was going to say thyroid, but got beat to that punch.
Would hypothermia be considered metabolic disturbance?
Man, you're just taking them all, aren't you? There you go, temperature. So hypothermia being the most common thing that we think about, but even hyperthermia can lead to altered mental status too. Typically, temperature below 34 Celsius is where you start to worry about that being a component. So great things for everybody to say. Obviously, when we do an ABG post-op, you're able to look at oxygen, CO2, your pH. You're able to look at what your glucose is, what your electrolytes are, specifically your sodium. So really, most of the things on this metabolic disorder you're going to get with your typical ABG. So that's why that's an important test to kind of rule things in and rule things out. Any questions about these metabolic contributions to delayed emergence?
I had a question for you. Would you ever see that maybe with like severe adrenal insufficiency?
Yeah, so you actually can see that with severe adrenal insufficiency. And interestingly enough, in those that are hypothyroid and severely hypothyroid, you can have then a causative adrenal insufficiency because of the thyroid disease. So primary adrenal insufficiency is less common, but usually it's acquired by hypothyroid. But yes, you're exactly right. So adrenal dysfunction, insufficiency can contribute.
Yeah, I totally thought it was related to thyroid. That's definitely why I said that, obviously.
Yeah.
Tony.
All right, last one. Yeah, go for it.
Oh, regarding sodium and temperature, I've had a couple of like oral board questions and stuff come up about those. How do you approach, like, if somebody has a low sodium prior to the case that's kind of out of nowhere, maybe you don't have any priors, at what point do you say maybe we should probably delay this case, or like maybe what level of sodium is like super concerning, and get it worked up? And then the same thing with temperature. I had a couple questions about what temperature it's safe to extubate somebody at.
Yeah, so let me get to your first point on sodium. There's really no set number necessarily of where you start to worry about canceling a case. I think it's more important for you to understand the trend. So you'll see this in patients that have really bad liver disease, your liver cirrhosis patients. When they get really end-stage liver disease, they can get very hyponatremic, but they get there over a period of time. And so it's not an acute drop. And it's really something that if you have these acute changes, that's where you get a lot of the neurologic sequelae. If you have slow changes and they get used to it, you have compensation mechanisms so that they have ways to deal with it so that you don't see as many neurologic issues. So it really depends quite a bit on that temporal association of how far does it go, how quickly does it go down. I would say if you just came in, have one lab value to go off of, if a patient's below 125, I think that's a reason to say, well, you know, this may not be something that is major, but we probably should work up why it's 125. So I think for sodium, that's probably a reasonable number to use if you have no other data. With respect to temperature, on oral boards specifically, I think there's no set number out there that says at 35 degrees, the patient's safe to extubate. I think for the purposes of the oral board exam, you're always safe by saying, I'm going to get the patient back to normothermia, 36.0 or higher, before I attempt to extubate. Now, you probably could extubate them earlier in practice, but on an examination, I think to say that you're going to want to have a normothermic patient is the way to stay safe on those questions.
Thank you.
Any other questions? All right, so this one, there's not 8 answers, there's only 6 on this one, so but a little bit more abbreviated. This one is name a neurologic disorder that contributes to delayed emergence. A neurologic disorder that contributes to delayed emergence. And some people have said some things already. So let's go with Nate Reitberg.
Stroke.
And I'm going to push you a little bit. What kind of stroke?
We'll say ischemic.
Perfect. So ischemic stroke. So I think you got a soft serve, Peter Coleman, if you want to go with the other type.
Hemorrhagic.
You got it. So you can have hemorrhage. Good. Sam Jensen.
Seizure.
Good. Ted.
Dementia.
So I don't have dementia on here, but I'm going to kind of give you something that, you know, sometimes is confused, especially in the postoperative period, but delirium. Lansing.
Oh, we are getting far down here for me. Trying to think of some medication that we may have given that was neuroactive, but that would really be under the something
You're
else.
right. That's, yeah. All right, we're going to phone a friend. AJ.
All right, I think I'm on mute. Myasthenia gravis.
That is something that I don't have on here, but that's definitely something. If you have a myasthenic crisis, that's exactly right. You could have some neuromuscular disorder that is contributing to that. So it's not on here, but great idea. Claire.
Elevated ICP.
Good. ICP. So that could be something that's acquired or something that, you know, is related to the pathology. Maybe they got into some sort of traumatic fall or car accident. And the last one, I'm not going to have anybody guess because that's, again, a little bit of think what I'm thinking. But it's a little bit more all-encompassing of what we talked about earlier, which are psychiatric disturbances. So you can have various forms of psychiatric issues that can arise in the postoperative period that can mimic this delayed emergence or contribute to it anyway. So these are big things. Obviously, this is, at least for the most part, not anything that you're going to be able to deduce at the bedside in the PACU, for example, but there are some things that you can do. So a neurologic exam is something that we can do. We don't do a ton of, so let me see, let me pick somebody. David Mack, either in the chat or unmute yourself. What components of a neurologic exam might you do in somebody that is not responding?
I would look at things like corneal reflex, pupillary response to light, kind of focus on some of the cranial nerves to see where we're at with that.
Yeah, so that's actually right. Cranial nerve function is going to be one of the easiest things for us to do. So gag reflex, corneal reflex, your eye pupil changes to light. Those are things that are really easy to do. If it's somebody that's not responsive but can move, you can do some, fingernail bed squeezing to try to cause pain and cause them to withdraw to see if they withdraw to pain in the various extremities. So there are things that you can do to look at their neurologic status, but of course, nothing is going to be very clear unless you get imaging in most of these situations. So kind of getting back to our case, based on what we've talked about so far, what you can put in chat or you can put, unmute yourself. What do you think are kind of the leading, maybe 1, 2, or 3 differential diagnoses?
Hey, Tony, for those of us that joined a little later, could you give us like a 2-liner of the case?
I can.
Or maybe have it pulled up, sorry. I'm not actually watching the screen.
I had it at the beginning, but I'm happy to quickly show it.
Awesome. Thank you.
So this is a 54-year-old man who had complex spine surgery. He has hypertension, diabetes, hypothyroid, renal insufficiency, sleep apnea, chronic pain, obesity, bipolar disorder, and GERD. And this is a patient that at the end of the procedure, there was a lot of EBL, but was relatively hemodynamically stable, just not waking up at the end of the procedure, and then not waking up in PACU, so was taken to the neuro ICU with the breathing tube in place.
So I think top of my differential is going to be residual anesthetic, probably from a combination of kidney or liver insufficiency or failure.
All right, so what if I told you then, if you're thinking about, let's say propofol. Propofol in most cases for spine cases and patients that don't wake up is number 1, 2, and 3 on your differential. So what if I told you that the patient was maintained on 125 for their setting, and this is a patient that has, I think, BMI of 32, so not crazy obesity, but was on 125 of propofol until about 1 p.m. I'm sorry, that's not true. At 8 a.m., so just early, it was changed to 100 right away, and it was then changed to 85 at 10 a.m., 75 at 1 p.m., and then off at 2:30. So if this is now, let's say, 7 p.m., do you think that propofol is still in the differential?
It really shouldn't, but I did have a patient who took many hours to wake up who had unrecognized renal insufficiency and some liver insufficiency as well, kind of in a similar situation. So I always think of that first.
Yeah, no, I think that's great. Any other thoughts?
I mean, you still have a lot of, inherent metabolic and hormonal disorders in this guy. I mean, bipolar could be on lithium, prolonging his neuromuscular blockade. Hypothyroid could be just uncontrolled. Diabetes, hypoglycemia, maybe he hit too much insulin before. So just his inherent disorders that he already has.
And
Yeah,
Dr.
you're exactly right.
Was there any concerning neurologic findings in the PACU at all?
Not in the PACU, but I'll tell you what happened when he got to the ICU.
I guess just based on some of those dips intraoperatively, maybe a concern that there was some sort of ischemic stroke intraoperatively, potentially.
Yeah, definitely. So just to kind of finish what happened in the OR as far as infusions go, somebody had mentioned Precedex as being something that could be contributing. This patient was on 0.1 of Precedex really from about 9 a.m. till the end of the case, pretty low dose. I think total dose that the patient got was about 1 per kilo. It was not very much. Ketamine is also something that the patient was getting as an infusion. His ketamine infusion was at 20 for about 3 hours, and it was changed down to 5 per hour starting at 11 a.m. and off at 2:30. So again, his total dose was maybe 85 or so milligrams, was not very much. Lidocaine infusion, he was on 0.5 milligram per kilo per hour. That was started at about 9:30 and off about 3 o'clock. Again, far away from what would be considered a toxic dose for him. So given the time course of everything, it's unlikely that the IV anesthesia could be contributing. But, this is something that we think about, just like what Cindy said. You have patients that for a variety of reasons, could be liver issues, kidney issues, might not be metabolizing or eliminating the medications. And so this is one case that was discussed in the literature that was looking specifically at the genetic background of somebody that has slow propofol metabolism. And so my CA1s had lecture of this from Dr. Eckel on some of the cytochrome P450 enzymes. So this is a question that I hope somebody can answer easily. Which of the following P450 enzymes is most responsible for propofol metabolism? And I'll just let anybody put it in the chat what they think it is. All right, Sam says 2d6. David says 3a4, 3a4 for Claire. So 3a4 is a very common one, and I'm not surprised that people are selecting that one. 2d6 is also very common. So the 3a4 is probably the most involved with the medications that we give. It's involved in fentanyl, it's involved in midazolam metabolism, sufentanil metabolism. It does do a little bit of propofol metabolism, so those that answered that are not incorrect. However, the one that's most responsible for propofol metabolism is actually D, which is 2b6. So 2b6, as Cindy said, is correct. 2d6, which is B, is really important for your opiates. So really these 4 different enzymes that are involved in metabolism are the ones that are most important for us in anesthesia. And so for those that are 2d6, the way I remember at least this particular one is that D, I think of codeine as the D there, and this is the one that's responsible for making codeine or converting codeine to morphine. And so that's one that a lot of people have polymorphisms that either they can't metabolize codeine or they do so too quickly or too slowly. And then again, 2b6 is going to be the one specifically for propofol, but it also, as somebody, it looks like David Maurer just said, D for Dilaudid. That is also true. The 2b6 is mainly that propofol. There's a couple of other agents that are metabolized that way too, but this is something that you could see on an exam. All right, so let's get back to our patient. This is what, just a summary again of what that patient presented for. So in terms of what happened, so in the ICU, the nurse noted sometime after we dropped the patient off that the patient had occasional intermittent rhythmic head movements. And it sounds like this is something that was not very well documented in the chart, but it sounds like the intensivist also saw these and at that point decided to do a couple of things. So before I go into what the patient got done, let me have you go through this question. In a patient with status epilepticus, which of the following medications is most appropriate first-line treatment? Again, put that in the chat. So it's a wave of A. A is correct. So your benzodiazepine is correct for giving as a first-line agent. Does anybody have any sense what dose of lorazepam you give?
2 milligrams.
So 2 milligrams is a good starting spot. The actual number that people will look at is 0.1 milligrams per kilogram. So that gets you, for most patients, kind of a starting point, but it's not something that is going to be usually enough to go ahead and cause the status to break. And so you have to have more on the order of 5 to 10 milligrams of lorazepam to really get that to break. The phenytoin and fosphenytoin is a really interesting medication that also can have cardiac effects. If those of you that are on neuro ever have to give fosphenytoin in the OR, you'll notice that you get a lot of hemodynamic changes when you infuse it quickly. But phenytoin administration or fosphenytoin administration should be done pretty much concurrently with your lorazepam. So in a way, that's also first-line treatment. You try to do the lorazepam first and give a concurrent phenytoin bolus as well. Propofol and phenobarbital are agents that are very effective at breaking status. And what you shoot for in both those cases is you're looking for an isoelectric or burst suppression EEG. So those are the things that all of these things can be used to help break that. If you have a patient that is having a seizure intraoperatively and it's because they are working on a tumor, let's say in the cranium, that particular situation where they're having a seizure can be quenched by putting cold irrigation, ice irrigation onto the field. All right. So, all right. So again, rhythmic movement. What are you talking? You talking about the person driving?
Somebody was being a dummy on the road. Sorry.
It's all right. All right, so patient has some rhythmic movements. What the intensivist did was he gave a bolus of Keppra, and he ordered a continuous EEG. And so the EEG didn't get put on until about midnight, maybe 12:30 on the day of surgery. And the report from that EEG, I think it was about a 12-hour or so EEG tracing, is that the patient had 5 intermittent seizure episodes that were originating in his posterior occipital lobe, and doing so, I think it was on the left side. And so this patient was having seizures. It wasn't status epilepticus, but it was having seizures. And so maybe what's going on in this patient is that he was having some periods of post-ictal, sedation or obtundation because of the seizures. What's interesting after that particular situation of having seizures for him is that he got an EEG every single night for about 5 or 6 nights. And the only night that he showed activity for seizures was the very first night. So this is something that you'll see, and there actually, this case report here shows that in a spine case, even a low lumbar spine case, you can actually get some impact in the head that you might not ever imagine. And that usually is a result of them getting into the dura. You have either an unrecognized or undiagnosed dural tear, and then you have a loss of CSF that then makes the brain sag. And so you can get what are most commonly going to be cerebellar hemorrhages, which this case talks about, that then lead to seizures. So you can have something that is in the brain, usually blood in the brain, that can lead to seizure activity. Something else that can be seen is, in this particular case report, this is a patient that had a tumor resection. So this is a craniotomy, and had unrecognized venous thrombosis in the cerebral venous sinuses. This patient actually ended up dying, so it was a very catastrophic result, but that's something you also want to consider too, and that's why imaging is going to be important. And then the last thing that I'll put on here is really an interesting piece that, if they were to get into the intrathecal space, either inadvertently or intentionally, but repair it, the patient is at risk for meningitis, and that's something that is has to be on your differential as you are considering what to do for the patient. So not very common. It is rare. They found 21 cases over the course of about a 10-year period, 20,000 patients that had spine surgery that got meningitis, but it does happen. And the reason why is, as I said, this patient on day 3, 4, and 5 was not having any seizure activity, was not on any sedation, and still wasn't waking up. And so you have to ask yourself the question, what else is going on? And in that particular instance, it was about, so the surgery was on 8/27. On about the 2nd of September, so 9/2, they went ahead and did an LP. And lo and behold, they found a pretty dirty looking LP. It was cloudy instead of clear. It had lots of white cells. It had lots of red cells. It had lots of protein. And so it had the appearance of a bacterial meningitis. And so they started empiric antibiotics for presumed meningitis. The other really interesting thing about this case is that they decided to go ahead and draw a bunch of other labs about the 5th or so of September. And those labs were really looking at, again, thyroid function, because again, this patient came in as hypothyroid. He was on thyroid supplementation. His T4, free T4 was extremely low. And was there an overlying component that was related to this patient having a hypothyroid myxedema type picture? So lots of things that were kind of layering on one another. And then the final layer, I think, is something that was, I think, difficult for me going back and looking at this record, which is an incomplete history. So as I showed you, he had bipolar disorder. When I pre-opted him, we talked about his bipolar disorder, we talked about his medications, but in the chart, he didn't have any medications listed for his bipolar disorder. And he actually was on several. He had, I think, 3 or 4 different medications. One of those medications was something called benztropine. Benztropine is, Cogentin is the brand name. Does anybody know or have heard of that medication before?
Yes.
Yeah,
Pepper
anticholinergic medicine.
Yes, you're exactly right. So it is a medication given to those that are taking psychotropic medications to help with extrapyramidal symptoms. And so this gentleman was taking it, and it's possible too that this person, this patient had a hypoactive delirium throughout this process too that could have been complicated by some of these polypharmacy him pre-operatively taking. And so long story short, we've gone through multiple things that could be causing this patient delayed emergence. He didn't get extubated until about the 5th of November. So he was intubated for about a week and a half almost. And even when he was extubated, he was not really coherent for another week or so. He had episodes of delirium. So depending on the day and time, he would either be coherent or he would not be. So a very complex, complicated picture. Not really sure what caused what, but all in all, this is a really neat way to talk about delayed emergence. Extreme case, but one that has lots of layers for you to consider. So with that said, let me go back to my slide. The workup, you want to make sure your vital signs are intact. That includes temperature. You want to make sure that there's no reason from a vital sign standpoint that you have concerns. You want to make sure that the person's strong. Make sure that they don't have any reason to be weak. You want to make sure that you do a neurologic exam. We talked about some of those reflexes to go ahead and look at. You want to look at serum glucose, make sure it's not too high and not too low. You want to look at an ABG with electrolytes, looking at sodium, looking at pH, looking at your PCO2 and your PO2. And then reversal agents is kind of the final piece in terms of what we would do. And so we have reversal agents at our disposal. The common ones, of course, are going to be naloxone and flumazenil. Those are the things that we use most often. I've actually only used flumazenil once in my time as an attending. I've used naloxone a lot more often. But there's also something else that I've not used but can be used, which is pyridostigmine. If you're worried about cholinergic or anticholinergic effects, pyridostigmine is something that can be used as well. So that is kind of a third reversal agent to consider in these patients. And then the last piece is going to be imaging. This patient got a head CT the day of surgery, unremarkable. We had a CT scan for probably 4 or 5 days. None of them showed anything. He finally got an MRI. That didn't show anything either. So the risk of some anoxic process, ischemic process, or hemorrhagic process intracranially was not observed the entire time. All right, what kind of questions can I answer?
On that anticholinergic pyridostigmine move, since it's not usually in our cart, is neostigmine an appropriate substitute, or is it too short acting?
The problem with neostigmine is that it doesn't get into the central compartment, right? So you need to get something in the CNS, and pyridostigmine is the agent to do that.
Gotcha.
Could this have also been like a prolonged post-ictal period for being seizing? We don't know for how long, but like a prolonged post-ictal, because he did seize that first day, if I remember correctly.
That's right. Yeah, that's right. When I talked to the person that took over for me and the person that dropped the patient out, they never saw any of these movements, these head movements. And so it's very possible that the patient did have some either unobserved seizure and was post-ictal. That is exactly, I think, probably what happened. as I said, he was on 75 for his propofol infusion for a big chunk of the case, not a very high dose, yet his SedLine reading was in the low 20s, up to upper 20s, maybe low 30s. And so maybe he had something kind of organically going on throughout the case that just was not realized until afterwards. So that's definitely something.
Hey,
Any
Dr.
other
Oliva,
question?
I have a question for you. I was hearing about these like new drugs like doxapam, and like they're like respiratory stimulants, or like they are supposed to stimulate you to wake up faster. There's some use in like private practice to get the cases going faster. Is there been any like purpose of these to try to like help patients, like in either like trying to figure out what's going on or trying to get them to breathe or wake up faster?
Yeah, you're exactly right. There are agents that are coming online, and I think they're going to get better and better in all of your careers, where we're going to have agents that either will directly compete with propofol or other anesthetic agents for that GABA receptor, and you can have reversal pretty quickly. And so I think that, yes, you're going to see that, and yes, it's reasonable when we have those agents available to use them to see if you can tease apart what's going on. Sam Jensen asks, can you see seizure activity on the SedLine monitor? In theory, you can. However, you have to remember that the SedLine is only frontal. So you remember in this situation, he was having posterior occipital seizure activity. So you would have to have leads in the area where the seizure focus is in order to see it. All right, this is a great case, food for thought. This is always something that comes up on oral board exams, so make sure that you kind of review your differentials and keep thinking about how you can intervene and prevent some of these things from happening. Have a good afternoon, everybody.